So jumping into basic 12-lead EKG interpretation, the objectives for this portion, we'll return to the basics of 12-lead EKG interpretation and review the following: lead placement and coronary artery anatomy, recognize and localize a STEMI on a 12-lead EKG, understand the pathophysiology of an MI, and accurately determine and identify a STEMI. So the 12-lead EKG printout, and for those of you who have been in our CE program for the full 4 years now, you've seen this every single year, like I already mentioned, and I think it's important to keep it in there because I think it's a common misconception that not for all providers, but there's still some providers out there, and I see them, in my full-time position occasionally. Sometimes we invest too much into what that 12-lead EKG printout is actually telling us is wrong with the patient, instead of taking the time to manually review the 12-lead EKG and go through our systematic process, look at each lead individually and see, do I have any ST segment elevation or do I have any ST segment depression? So remember that far right column where in this one, if you can kind of see in the background, it says normal ECG unconfirmed. That information could be correct or it could very well not be correct. So just kind of take everything that it tells you there with a grain of salt. And to give you a really recent example of that, in my full-time position with Hebron Fire as a captain of EMS there, doing QA, yesterday I took about 10 days off for the holidays. And when I got back in and started doing QA, one of our medics asked me about a run they had and to do a follow-up with St. E. So I started looking at this guy's 12 lead, and the printout said he was in sinus brady at a rate of 38. The guy was in SVT or AFib with RVR. We're waiting to get a follow-up at a rate of well over 200. So that information is not always going to be correct. You have to be able to fall back and rely on your abilities to interpret the 12 lead or the 4 lead or whatever it may be. Now, the information in the middle column, the diagnostic information with the numbers, that is accurate. You can take that information to the bank 9 out of 10 times. If it's giving you a measurement, it's a good measurement. Now, it doesn't mean the patient's not moving or there's not artifact. It can't help that. But if it's giving you a measurement, it's pulling it from somewhere. Coronary artery anatomy. So one thing in 12-lead EKG interpretation that I don't think we really talk about enough or really even focus on enough, we certainly don't in paramedic school, and that's because we just have the objectives of teach the basics of 12-lead EKG interpretation to make you an entry-level paramedic and send you on your way, is we never really look at conduction system perfusion. Now, I'm sure some of you have on your own, but generally speaking, through a paramedic program, unless you're going to get this information through continuing education, there's a chance you may never really review it. So I think it's important to take a few minutes here to look at this. It's a pretty good graphic, although there is an error on how they have two things labeled, and I'll point that out when we get there. So anything with a blue arrow, a dark blue arrow on the screen, is supplied by the right coronary artery in the majority of patients. So the SA node, or the sinoatrial node, that is supplied in 60% of patients, that is supplied by the right coronary artery. And the other 40% of patients, that is supplied by the left circumflex. The atrioventricular node, or the AV node, as we work our way down, 90% of patients have that supplied by the right coronary artery, and 10% of patients have it supplied by the left circumflex. And if we jump over to the bundle of His, it's mainly supplied by the right coronary artery. And then as we jump down, it's labeled as posterior fascicle, but that's actually the anterior fascicle of the left bundle branch. That is primarily, it can be supplied by the right coronary artery, or it can be supplied by the left anterior descending. It really just depends on the patient population. So with that, if we have a patient who has an inferior wall MI, and we're not even going to talk about right ventricular MIs right now, but if we have a patient that is having an inferior wall MI, there's a chance that we are going to see that patient be bradycardic. And why is that? Well, we know that the inferior wall in the majority of patients is supplied by the posterior descending artery, which we're going to look at in a couple of slides. That posterior descending artery is ultimately supplied by that right coronary artery. So depending on where the occlusion is in that right coronary artery, is it proximal or is it distal? We can start to see some heart rate effects from that occlusion and from that clot. So it's very well likely that we take out our primary pacemaker, our SA node, and then we could potentially even take out our backup pacemaker in that AV node, and we ultimately get down to where my entire heart rate is functioning off the bundle branches, which, as if you can remember, generally that's a heart rate somewhere between 15 and 40 beats per minute. So if we take a second to look at the green arrows, those are all supplied by the left anterior descending artery or the left coronary artery. So the right bundle branch is supplied by the left anterior descending artery. The left bundle branch proximally is supplied by the left anterior descending. And then, as I mentioned, as we get down into our anterior and posterior fascicles of that left bundle branch, it can really be a mixture. It truly depends on what collateral circulation has occurred with the patient, and a variety of other things. As the SA node supplied by the right coronary artery is the SA node supplied by the left circumflex. So there's some variables once we get into the anterior and posterior fascicles of the left bundle branch. But overall, I think this is a pretty good image in looking at when we have a right-sided MI patient, whether it's an inferior wall MI or it's a more proximal occlusion and it's causing an inferior wall MI and a right ventricular MI, we're absolutely going to see some heart rate changes from that, and their patients are most likely going to be bradycardic because their pacemakers aren't getting oxygenated blood flow, which is going to cause problems. So left coronary artery anatomy. This supplies the left ventricle interventricular septum, which is that septal wall that separates my right and left ventricles from one another. Part of the right ventricle and the heart's conduction system, which we just looked at. There's two major branches of the left coronary artery that we really focus on in the pre-hospital setting. That is the left anterior descending artery, as you see there coming down the anterior portion of that left ventricle, and the circumflex artery, which flexes or wraps around that lateral wall of the left ventricle and eventually becomes posterior on that left ventricle. Right coronary artery anatomy. This supplies portion of the right atrium, portion of the right ventricle, the inferior wall, and part of the conduction system. There's two major branches that we focus on pre-hospitally. That is the marginal branch and the posterior descending artery. So hopefully you can see my mouse on the screen here. As we come down, you see our aorta here, just to kind of get our bearings in terms of what we're looking at. Everybody should be able to recognize the aorta. As you move to the left of that, you see your superior and inferior vena cava and your right atrium. And then you see this large vessel, which is the right coronary artery that comes down the right side of the heart. As we work our way down the right side, or that right coronary artery, when we get to near the base of that, you see that there's a bifurcation of that vessel. One part of that vessel wraps around the heart, which we'll talk about in a minute, and goes to the posterior side of the right side of the heart. And the other vessel continues down the inferior portion of the heart into the right ventricle really through the bottom of the right ventricle and into the left ventricle. That is the marginal artery. So the marginal artery is what is responsible for supplying the right ventricle. So that's going to come up later as we start to look at inferior wall MIs and V4R, as we've done in the past with this lecture. So keep in mind that marginal artery right there, that primarily supplies that right ventricle. And then as we jump around to the back, so if I look over to the right side of this, you can see that posterior descending artery where it bifurcated and wraps around the posterior side of the heart and back to the down to the inferior portion of the left ventricle. So if we have an occlusion in our posterior descending artery, that is going to cause an inferior wall MI. If I have an occlusion in only my marginal artery, that is going to cause a right ventricular MI. If I have an occlusion that is proximal to both of those and is in my right main coronary artery, now I've shut off blood flow downstream, and I'm going to see STEMI patterns in both my marginal artery for my right ventricle and my posterior descending artery or my inferior wall. 12-lead coronary artery relationship. So this is a pretty good picture to demonstrate the leads that we look at on a 12-lead EKG and exactly how they're supplied. So the aorta doesn't necessarily supply AVR. It doesn't at all. It's more so there, again, just for kind of bearings of where these vessels are coming from. The left anterior descending supplies my septal and anterior leads, so V1, V2, V3, and V4. My left circumflex supplies my lateral leads, so 1, AVL, V5, and V6. And my right coronary artery, more specifically, my posterior descending artery, supplies 2, 3, and AVF, or my inferior leads. So this is a critical concept to understand. The 12-lead EKG that we do in the pre-hospital setting only looks at the left ventricle, period. It doesn't look at the right ventricle. It doesn't look at the left atrium. It doesn't look at the right atrium. It only looks at the left ventricle. So if you can understand that, which I'm sure most of you do, it makes sense kind of where all of these cardiac regions are when we start to have injury and necrosis, right? So our lateral wall, or leads 1, AVL, V5, V6, those are correspond with our lateral wall of our left ventricle. The anterior leads, V3 and V4, those correspond with the anterior wall of the left ventricle. My inferior leads, 2, 3, and AVF, they correspond with the inferior portion of my left ventricle, and my septal leads, V1 and V2, correspond with my interventricular septum, that septal wall that separates my left and my right ventricle from one another. So at the end of the day, if you understand that, you realize that septal, anterior, lateral, inferior, they're all just anatomical terms that weren't born out of nowhere, that all correspond with which region of the heart is actually infarcting in the patient that you're sitting there looking at. So 12-lead mechanics. So lead placement. Limb leads must be placed on the limbs. And this was a pretty big pet peeve of mine teaching the paramedic program. And it was one of the things that I tried to get on a soapbox on and really drill into the heads of students. And I know that that habit or practice can change. And I'm not throwing stones at anyone who puts them on the torso. I've put them on the torso because I just don't have great access. The patient's wearing 16 layers of clothing, whatever it may be. But limb leads are truly designed to be placed on the limbs. So on the upper arms and the thighs, or the ankles and the wrists. The ankles and the wrists can be challenging because of patient movement. I understand that. But for their best view and the way they are intended to view, they should be placed on the patient's limbs. The precordial leads, those are the chest leads. So those are V1, V2, V3, V4, V5, and V6. So V1 goes in the fourth intercostal space to the right of the sternum. V2 goes directly across from that in the fourth intercostal space left of the sternum. Generally, we hop down here and put V4 on at the fifth intercostal space, the left mid-clavicular line. And then V3 comes up here and goes directly between those. And then V5 is at the same horizontal plane as V4. V5 goes left anterior axillary, so the front of the armpit. And then V6, again, same horizontal plane, goes at that fifth intercostal space, mid-axillary, so in the middle of the armpit. If you really pay attention, both in the field and in the hospital setting, for some reason, we start to take V4, V5, and V6, and we start to do this wrapping pattern where we start kind of ascending our leads as we wrap around our patients' backs. And again, I'm guilty of that as well. I'm certainly not going to act like I'm not. But proper placement should be V4, V5, and V6 should really be in a straight line in that same horizontal plane as one another when we're applying them. So this is just a real quick example of limb leads being placed on the torso, and then on the next slide, limb leads being placed on the limbs. So it doesn't make a tremendous difference in this patient specifically It's not like we're seeing no STEMI pattern to a STEMI pattern or ST elevation all over to no ST elevation all over, but it does certainly make a difference. And I have lead 3 highlighted here, but also pay attention to what leads 1 and I believe 2 look like in this image compared to the next image I'm going to show you, where the limb leads are actually placed on the limbs. So in lead 3 here, we do have a little bit of ST segment elevation. Again, hopefully you can see the mouse the way that I have it there. But we can see a little bit of ST segment elevation. Now I don't have it in any other anatomically contiguous leads in 2 and AVF, so it really doesn't make a huge difference from a STEMI recognition standpoint. Although isolated ST segment elevation in lead 3, along with some other factors, can be a sign of a non-STEMI. But regardless, we see a little bit of an ST segment elevation there in lead 3. When I jump over and I put these patients' limb leads on their limbs, that ST segment elevation is gone. And I have a pretty significant change in amplitude in leads 1 and 2. So I'll jump back. So leads 1, 2, AVR, AVL. My precordial leads aren't affected because those are my chest leads. But I'm going to see where I'm going to see those changes are in my limb leads. So if you look at leads 1, 2, and 3, these are the torso placement, and you jump back to the limb leads, there's definitely some amplitude change and really even some morphology change there in the shape and size of my QRS complexes. So it's something to think about. There's a lot of examples out there that you can look at. There's a lot of studies that you can look at out there if you'd like to, that kind of dive a little bit deeper into why limb leads should be on the limbs just from their view in Einthoven's triangle. So a normal 12 lead does not rule out an AMI. So if any of you took Hebron's EMS refresher last month, last year it was, I did a non-STEMI lecture, and I know Adam's done that same lecture for Pass with Pass for you all, and I'm sure it happened in 2023. But if you've heard either one of those lectures, you should know a normal 12 lead does not rule out an acute myocardial infarction. So we always used to think that STEMIs and non-STEMIs happen about 50% of the time from one another. So there's a 50-50 chance. If the patient's having an MI, there's a 50-50 chance it's going to be a STEMI. There's a 50-50 chance it's going to be a non-STEMI, and we're not going to be able to see anything in the field. Those numbers are changing, and really they're changing out of our favor. So now the more recent statistics show non-STEMIs are happening 70% of the time in our AMI patients, and STEMIs are happening 30% of the time in our AMI patients. So don't let the 12 lead itself gauge your treatment on what you're going to do for that patient. So what I mean by that is, don't do a 12 lead and think, the patient doesn't need aspirin or nitro. The 12 lead looks fine. You still have to treat your patient at the end of the day. And that's with any piece of equipment we have in the back of the medic unit, whether it's pulse oximetry or a blood pressure cuff or 4 lead, whatever it may be, we still have to treat our patient at the end of the day. And if my patient looks like crap and they feel like crap, they're having chest pain, they're cool, clammy, diaphoretic, their 12 lead might look better than what mine does personally. But I'm still going to treat my patient as if he or she's having an acute myocardial infarction, because at the end of the day, 70% of the time, I'm not really going to be able to pick up on that on the field. So keep that in mind when you're doing 12 leads. Also, watch what you tell patients. I've ridden with several medics who have, and again, I've done it myself, where, you're not having a heart attack, we're going to run you up to the hospital, right? And afterwards, you stop and think, like, man, I really hope they're not having a heart attack because I just told them they're not. So really watch what you say and maybe change some of that verbiage for the test that we can use. I don't see anything that says you're having a heart attack, but they need to do some additional tests at the hospital and blood work to rule things in or out, right? It's telling the patient what you're seeing, but it's also telling the patient that they're not out of the woods at this point and more tests need to happen. So the J point. The J point is the junction between the QRS and the ST segment. So if you have measured a QRS complex, which I suspect 100% of paramedics on here have, you have found the J point. The J point is where our QRS measurement stops. So again, the J point is the junction between the QRS and the ST segment. And that is really what we're looking for on each of those lead groupings to identify where our ST segment is so that we can compare it for ST segment elevation or ST segment depression. The ST segment, this is the area between the S wave and the T wave. This is obviously where ST elevated myocardial infarction gets its name. So the J point is kind of the beginning point of that ST segment. And that ST segment is what we're going to be using to identify, is this patient having a STEMI or not, based on its height or depression compared to the following TP segment. So if that ST segment, which is in purple here, is higher than the blue line, which is our TP segment, if it is higher than that TP segment by 1 millimeter or more, which is one small box or more, this may meet STEMI criteria. And I say may because we have to, it's got to happen more than once in one lead for us to be able to say, yep, that's a STEMI, right? It has to be happening in 2 or more leads that are anatomically contiguous or numerically consecutive, which we'll talk about here in a few minutes. But we are using that ST segment and we are comparing it against the following TP segment. And I think that's probably the biggest takeaway from this slide is, when I started off as a paramedic, I was just looking for any ST segment and I was looking for any halfway straight line that I could compare it to that I felt was isoelectric, right? And what we really need to be looking for is that following TP segment to be able to gauge, is it higher than, equal to, or lower than. Evolution of a STEMI. So if we were able to actively watch somebody's 12-lead EKG who is infarcting right in front of us, this is kind of that progression that we would see as they're actively infarcting. So the very first thing we would see are hyperacute T waves. So hyperacute T waves by definition is an upright T wave that is at least 2/3 the size of the QRS complex. So it has to be at least 2/3 the height of the QRS complex or taller. That's the very first sign of the injury pattern we would see, are those hyperacute T waves. Then we would eventually see ST segment elevation. So my J point and ST segment is now higher than that following TP segment. So I have some ST segment elevation pattern there. And then eventually a pathological Q wave, which may or may not present itself. And we're going to talk about what pathological Q waves are right here. So physiologic, remember physiologic means normal. Physiologic Q waves are less than 0.04 seconds or 1 small box in duration. Those are a normal finding. Pathological Q waves are more than 0.04 seconds or more than 1 small box. And that is not a normal finding. So if any of you have done a 12-lead EKG and you've seen something at the top, and that portion that I told you earlier in the very beginning of this, don't really invest too much into that. If you see some type of language that says inferior infarct, age undetermined, or lateral infarct, age undetermined, or whatever it may be, what that monitor is picking up on are pathological Q waves in those corresponding leads. So for example, if it says inferior infarct, age undetermined, what it's actually picking up on are pathological Q waves. So Q waves that are greater than 0.04 seconds or 1 small box in the inferior leads. So in 2, 3, or AVF. It doesn't necessarily have to be all of them. So here's an example of that. Here's a 12-lead. It says possible septal infarct, age undetermined. And if we look down at V1 or V2, we should be able to see a little bit of a Q wave. We really can't see it in V1, but we can see a wide Q wave in V2. That's just telling us that there's been an infarct at some time, or maybe it's actively happening now if we see that ST segment elevation. Now, the thing about pathological Q waves, we always used to teach in paramedic school that if the patient has a transmural wall MI, they will always have a pathological Q wave left behind. Remember, a transmural wall MI is when that MI or that infarct extends through the full thickness of the left ventricle. So the innermost lining of the left ventricle to the outermost lining of the left ventricle, that infarct extends through all of it. That is a transmural wall MI. It has nothing to do with the location of the MI, septal or inferior or lateral. It has everything to do with how thick did the infarct actually extend. Think of it as a burn. So we always used to think that every transmural wall MI, so a full thickness wall MI, left a pathological Q wave behind, and subendocardial wall MIs, which are partial wall thickness MIs, may or may not. Again, as things change and data changes and statistics change, we've also realized that that's not true either. Sometimes pathological Q waves will be left behind with transmural wall MIs, and sometimes they won't be. So really gone are the days where we're able to say, oh, there's a pathological Q wave. They must have had a pretty significant MI, a transmural wall MI. That's not necessarily the case. It could have been a pretty minor MI that they may not even know about, or it could have been a pretty significant MI. They don't really tell us anything other than there's previous damage there. So ST segment analysis. So I have 6 different ST segments here, QRS complexes here to look at. So remember, if you were to measure the QRS complex to see how wide it is, where you would stop is where your J point would be. And that J point is the junction between the QRS, so really the S, and the ST segment. So take a few seconds here to look at these. Look at the top left is number 1, the middle, top middle is number 2, top right is number 3, 4, 5, and 6. Take a few seconds to look at those in your firehouses and just internally get a feel for, is there ST segment elevation present in those or not. All right. So let's look at the first one. And actually, when I go to the next screen, it's going to put it's going to identify the J points and the ST segments on every single one. If we were able to pinpoint the J point or the beginning of the ST segment in this very first lead, which it's hard to put a small enough dot and for you all to be able to see it. So that dot is certainly much larger than what it should be to identify the J point. I would put the J point kind of right in the center of that blue dot. If I drew a straight line off of that, I see that I'm pretty isoelectric and pretty even with my following TP segment. So I do not have elevation there. As I go to my middle, again, put my J point right in the middle of that blue dot. I draw my straight line over. And again, this line's a little bit thicker than what it truly needs to be, just so everybody can see it. I'm probably at about right at 1 millimeter of elevation there from my TP segment. It's hard to tell, I understand, by the quality of that paper. But I'm going to go ahead and say, yeah, I have a little bit of elevation there. As I jump over to lead 3, or not lead 3, picture 3, my J point would be right in the middle of this blue dot. If I drew a straight line over, I don't have much of a TP segment to look at, but I have enough of one. I'm about 2 millimeters of elevation there. As I come down to the 4th picture, which is a little bit deceiving, that's actually a right bundle branch block pattern. So I have a really wide QRS there. And these are my rabbit ears that we've talked about previously in other lectures. My J point would actually be all the way down here, marking my ST segment here. If I draw my straight line over, I'm actually maybe a millimeter depressed, so I don't have elevation there. My 5th picture, my J point, again, right in the middle of this blue dot. If I draw a straight line over, I have several millimeters of elevation. And my last picture, my J point's here, draw my straight line over to look at my TP segment. I'm isoelectric, so I don't have elevation there. Now, one thing I want to point out is we are trained and expected to identify any leads that have 1 or more millimeters of elevation. Don't be surprised if you take a patient into the ER and that has 1 millimeter of elevation and 2 or more numerically consecutive or anatomically leads, and the ER doc doesn't get too concerned about it. So from an ER perspective and a cardiology perspective, They generally use the rule of 2 or more millimeters of elevation in precordial leads, so my V1 through V6 leads, to really identify a STEMI. So again, don't be surprised if you take in, I got 1 millimeter of elevation in V1 and V2. I did a STEMI alert through Pulsera, and I don't have a lot of excitement when I get there because generally they're using the 2 or more millimeters of elevation criteria for those precordial leads. So the reason we're trained to look for 1, quite honestly, is it's a national standard, so that all paramedics look at things the same way. And you'll think of it as we are casting a wide net, and anyone who fits in a certain group of criteria goes into our net, and then we take that net to the ER, and that ER throws some fish back and they keep some, right? So our job is to kind of catch everyone who fits in this bucket. We take them along with us to the ER, identifying that, yep, they have ST segment elevation. And then through the emergency medicine physician, through cardiology, through past 12 leads, they then throw some back because it doesn't really meet STEMI criteria. The patient's not having a STEMI, or obviously some patients progress into the cath lab and so forth. So 12-lead EKG analysis, what to look for and where to look. So what to look for, we are looking for ST segment elevation. Again, 1 millimeter or more elevation, which is one small box. And that's present in 2 or more anatomically contiguous or numerically consecutive leads. So anatomically contiguous means they belong to the same family. So in this picture here, in the brown boxes, my lateral leads, 1, AVL, V5, V6, those are anatomically contiguous. Those leads all look at the same portion or the cardiac region of the left ventricle. My inferior leads, 2, 3, and AVF, those are anatomically contiguous to one another. They all look at the inferior portion. V1, V2, my septal leads, those are anatomically contiguous. They both look at the septal wall. And V3, V4, those are anatomically contiguous. They look at the anterior wall. So anatomically contiguous, that just means that the leads belong to the same family. They're looking at the same exact thing. Numerically consecutive applies to my precordial leads, so my chest leads, V1 through V6. So this is probably the most confusing part for paramedic students. It's like we teach them anatomically contiguous and we drill into their heads these lead groupings. And then we say, oh, by the way, you actually don't need to have elevation in 2 or more anatomically contiguous leads. If it's over here in V1 through V6, it can just be 2 or more numerically consecutive leads. So what do we mean by that? So if I have ST segment elevation in V2 and I have ST segment elevation in V3, then I have it nowhere else, that's enough to call this an anteroseptal wall MI. So I have 1 millimeter or more of ST segment elevation and 2 or more numerically consecutive leads. That is enough to call it a STEMI. Okay. So V2 and V3, that would be an anteroseptal wall MI. V4, V5, that would be an anterolateral wall MI. V4, V5, V6, still an anterolateral wall MI. It doesn't change anything. It just throws in an extra lead. So if we look at this 12-lead EKG, we see obvious ST segment elevation in 2, 3, and AVF, which are my inferior leads. I have, I can't see the small boxes on this paper, but several millimeters of elevation there in 2, 3, and AVF. If you remember back to the beginning, that is supplied by the right coronary artery, more specifically the posterior descending artery. Our next steps would be to check for a right-sided MI, and we're going to talk about that in a few minutes near the end of this section. So lead views. So the inferior wall, again, looks at the inferior portion of the left ventricle, leads 2, 3, and AVF. It's like I was taking a picture from the patient's left foot up near the bottom of their heart. The lateral wall looks at the lateral portion of the left ventricle, so the outside wall of the left ventricle. That's achieved through leads 1, AVL, V5, and V6. 1 and AVL, look at your high lateral wall. V5, V6, look at your low lateral wall. So, and this is demonstrated here by the 2 pictures on the right side of the screen. The top picture shows a camera taking a picture of that left ventricle from like the patient's shoulder, that would be looking at leads 1 and AVL, or the high lateral portion of the wall. V5, V6, or the low lateral portion of the wall, would be this camera angle down here, looking at the bottom of the lateral wall. Now, does it really make a difference to us what type of STEMI they're having, if it's high lateral or low lateral or all of it? No, it doesn't. A STEMI is a STEMI for us. We're going to treat it the same. We're going to take them to an appropriate facility. But just know that you can very well see ST segment elevation in only 1 in AVL and nothing in V5, V6 yet, although it's probably coming, because if I have an occlusion that's affecting upstream, I'm eventually going to have a problem downstream. But I could also have ST segment elevation in V5 and V6. So at the distal portion of that left circumflex, that low lateral wall, and I never really see anything at 1 in AVL. So just know that you don't have to have all leads 1 AVL, V5, V6. That's just 2 or more anatomically contiguous is what I need in order to be able to call that a STEMI. The anterior wall looks at the anterior portion of the left ventricle, and that is achieved through V3, V4. The septal wall looks at the septum that separates the left and right ventricles, which is achieved by leads V1 and V2. So now let's look at this. We have ST segment elevation in V2, V3, V4. I don't quite think, I think I'm just under 1 millimeter of elevation in V5. V1 looks a little funky, but I already have elevation in V2 and V3, so I really don't care about V1. It's not going to change anything for me. These 2 leads right here, V2 and V3, that's already enough to count that as an anteroseptal wall of my. V4 being thrown in there is just another lead showing an infarction pattern at that point. It's my second anterior lead. I don't need it to say it's STEMI criteria. It's just showing me the severity of the STEMI. V5, like I said, it's hard for you all to see. I know certainly on like projector screens, we're like just under 1 millimeter of elevation in V5. So I don't have septal, anterior, and lateral leads involved yet, but I would certainly take another 12 lead in about 3 to 5 minutes. And I wouldn't be surprised if I absolutely have 1 millimeter or more of elevation in V5, which would change the way we would name this. So this, as it stands now, is an anteroseptal wall of my. I have elevation in V3, V4. I also have it in V2. V2 is a septal lead. V3 and V4 are my anterior leads. Whenever I have an anterior wall MI associated with another type of MI, we always put that word anterior first. So anteroseptal or anterolateral. This happens to be an anteroseptal. Looking at this, I have another anteroseptal wall MI. I have ST segment elevation in V1, V2, V3, and V4. So I have another anteroseptal wall MI. I don't have enough involvement in V5 yet to call this an extensive anterior, which we're going to talk about in just a moment. And then again, another practice strip. I have elevation in 2, 3, and AVF. That is an inferior wall MI. Hopefully I'm thinking about moving up towards the moving V4 over to the right side and repeating my 12 lead to be able to rule in or rule out that right ventricular infarction. So reciprocal changes. So with reciprocal changes, think about it as generally we always see this in our inferior leads and our lateral leads. And it's because my inferior wall camera and my high lateral wall camera, so my 1 on AVL, they're kind of taking pictures from opposite directions of one another. So what one is seeing, the other is seen as a mirrored image, okay? So as for reciprocal changes, we don't have to have them. It's just extra evidence that, yep, what I'm seeing is true. I don't need to have it at all. It's kind of like the way I always taught it in the paramedic program was, I already have a STEMI pattern. I already have ST segment elevation in 2, 3, and AVF. Having reciprocal changes is just extra evidence, right? It's like I already have the crime being committed on camera. And now I have the suspect telling me he did it, right? I don't need him to tell me he did it. I already have it on camera. It's just extra evidence. By no means does it have to be present, but there's a very strong chance that it will be. And so what does that look like? So in this 12-lead EKG, we have ST segment elevation in 2, 3, and AVF, and I have reciprocal changes in 1 in AVL. So my high lateral camera, again, that's where I'm most likely going to see those reciprocal changes, if I do, for my inferior wall, because those cameras are looking at each other from opposite angles. I have ST segment depression in 1 in AVL. So if I have elevation in my inferior leads, there's a decent chance I'm going to have ST segment depression in my lateral leads, and vice versa. If I have ST segment depression in my lateral leads, more specifically 1 in AVL, there's a good chance I'm going to have ST segment depression in 2, 3 in AVF in my inferior leads. So again, I don't have to have reciprocal changes. It's always nice to note that, yep, I have an inferior wall MI with reciprocal changes, just because it's extra evidence that, yep, there is a STEMI there, and I'm kind of capturing it in 2 different views. So one type of MI that I briefly mentioned as we were doing some practice 12 leads earlier is, what if I have ST segment elevation in my septal, anterior, and lateral leads? So V1 through V6, my precordial leads. So that is called an extensive anterior wall MI, or the widowmaker. It's called the widowmaker because in 80% of patients, 80% of patients will die from having the widowmaker. So this all comes from a proximal occlusion of that left coronary artery. So if you see where this arrow is pointing, if I put a clot right there, I'm going to block everything downstream of that. So I'm going to block my circumflex artery, which supplies my lateral wall and my posterior leads, which we're not talking about today, and my left anterior descending artery, which supplies V1, V2, V3, V4. So my septal and my anterior walls. So we've always asked, when Adam and I are teaching this, we always ask students, if you had to have an MI, if I told you you're getting ready to have an MI, and I let you pick where you put it, you would want to put it as distally as possible, right? You would want to put it as far down in those branches as you possibly could, to where wherever that occlusion's happening, there's very little real estate distally to that that's going to be affected by it. So when we have clots that happen proximally in our right main coronary artery or our left main coronary artery, just know that everything downstream of that is going to be affected, and we are going to see infarct and injury patterns with that. So this is when we have ST segment elevation and leads V1, V2, V3, V4, V5, V6, or at least V2 through V5. And that is an extensive anterior wall MI, or the widowmaker, and about 80% of those patients are going to die with that. So I'm going to jump over for the sake of time for this section. So this is our extensive anterior wall MI pattern. So I have ST segment elevation in V2, V3, significant ST segment elevation in V3 and V4 and V5. I don't necessarily have it in V6 yet. It will be there if this patient doesn't get reperfused soon enough. But I have it in one of my septal leads and an anterior lead. So those are numerically consecutive. So minimally, I have an anteroseptal wall MI. I continue over. Yep, I have ST segment elevation in V4, which is an anterior lead. I come down to V5, which is a lateral lead. I certainly have ST segment elevation in V5. Now I have a septal involvement, anterior involvement, and lateral involvement. That's an extensive anterior wall MI. There's an 80% chance this patient is going to die from this. Right coronary artery anatomy. So again, the inferior wall MI. That is an occlusion of the posterior descending artery. So again, this artery that's shaded a different color, that's wrapping around the back of the right side of the heart here, that is supplying the inferior wall of my left ventricle. A right ventricular wall MI would be an occlusion of this marginal branch that we can see here on the front of my right ventricle. If I have, again, an inferior wall MI, so ST elevation in 2, 3, and AVF, We will move V4 over from the left side to the right side, and we will rerun our 12 lead. And the reason we're doing that is we are going to see if there's any ST segment elevation in V4R, so a right-sided 12 lead. If there is, that tells me that occlusion or the clot is proximal in the right main coronary artery. So it's somewhere above the bifurcation of my marginal artery and my posterior descending artery. It's somewhere above that, and it's causing effects downstream. If I run my right-sided 12 lead and V4R comes back totally fine, well, then I know the occlusion is not above that bifurcation. My right ventricle is not affected, and the occlusion is somewhere in that posterior descending artery alone. So why is that important? So we have always, oops, sorry, my computer went a little bit crazy there. We have always been told that if we have a right side, if we have an inferior wall MI, move V4 to the right side, repeat it to determine do we have a right ventricular infarct or not. So, and this rings true for current protocols and for current national EMS education standards. The thought process behind that of figuring out why is it important is because our right ventricle is responsible for preload. So it's responsible for filling, not under pressure, with an adequate amount of volume and pumping that volume into my lungs where it becomes oxygenated and then goes to my left atrium and down to my left ventricle. So the thought process is if my right ventricle is infarcting, as demonstrated by ST segment elevation in V4R, if my right ventricle is infarcting, it's obviously not doing well. It's not going to be able to do its job as effectively as it needs to. And now with nitro, I'm vasodilating and I'm causing lower pressures, and I'm making that right ventricle's job harder for it to pump blood to the lungs. So that is why we've always taught to move V4 from the left side to the right side so that we can determine where exactly is that occlusion, or at least with some degree of accuracy, because it's going to dictate what treatment we have for our patients. So we've always treated those patients with maybe hold off on nitro. If their pressure's good enough and you feel comfortable giving them nitro, you can if your protocol allows it, but make sure you have IV access in place and make sure that you have a 500 bag of fluids or a liter bag of fluids ready to go. The other part of that treatment plan has just been a fluid challenge and operating off of Starling's law. So remember, Starling's law is the principle that the harder or the greater you stretch something, if I have a rubber band and I pull it back really far and I let it go, the harder that rubber band is going to contract or going to slap. And that's the theory or the principle that we're working off of with this right ventricular MI and giving fluid boluses, is that we're giving more fluid to the right ventricle. We're causing it to stretch more so that it can contract harder and squeeze harder to move blood to the lungs. So we have always taught it that way, and I'm going to talk about some interesting statistics that are just coming out about that whole process. So I get an ST segment elevation in leads 2, 3, and AVF. Again, we're going to move V4 to the right side. And in this 12 lead, they move V4, V5, and V6. If you saw it real quick, it showed V4R, V5R, and V6R. You certainly can do that, but you also do not have to. V4 alone is 97% accurate in finding a right ventricular wall MI. So you can move V4, V5, and V6, all three leads to the right side and repeat it, or you can just move V4 over, and V4 is 97% accurate. So when I move V4 to the right side and I repeat my 12 lead, if I have ST segment elevation in V4R, then that tells me I have a right ventricular infarction along with my inferior wall infarction, or that elevation in 2, 3, and AVF. So under normal circumstances, that would tell us I need to withhold nitro, or at least be very cautious with nitro. And maybe this patient needs a fluid bolus first so that we can hopefully operate off of Starling's law, cause that right ventricle to stretch more and therefore contract harder. So this is pretty interesting here, and I know there's a lot of colors going on here, but hang with me. And there's also a QR code for this second research study that's in green. If you want to scan it and read it, it's pretty interesting. So the AHA, the American Heart Association, recommends that we withhold nitrates in the presence of a right ventricular myocardial infarction, and that is in both the 2015 and the 2020 guidelines. So that recommendation is based off a 1989 study of 40 patients. The dose of nitro was not captured in that study. So it could have been the correct dose, or it may not have been. And the routes were varied between sublingual, IV, PO, and transdermal. So in those 40 patients who were given an unknown dose of nitro via several different routes, 40% of those patients had adverse effects. And what they defined an adverse effect was a decrease of 30 millimeters of mercury or more in the patient's systolic blood pressure. So 40% of patients had adverse effects from that 1989 study. That is the reason that in 2024 now, we are continuing to operate and practice as if we should never, absolutely never give nitro to a right ventricular wall in my patient. And I've taught it that way for years. And I've tried to beat that in the heads of my students for years because they're going to see it in the field. They're going to see it on the national registry, right? And that's what AHA is telling us to do. So in 2023, Wilkinson, Stokes, Betson, and Sawyer, they did a meta-analysis, which is basically just a review of another research study. And that study was in 2017 of 46 patients. Nitro administered to inferior and right ventricular MI patients is more likely to cause an adverse effect, but it's statistically insignificant when compared to other cardiac regions. So what that means is, yeah, if we give nitro to a patient who has both an inferior and a right ventricular wall MI, they're a little bit more likely to have an adverse effect. But there's really not that great of a difference in the adverse effect or the rate of adverse effects those patients are going to see versus the adverse effect that my septal wall in my patient might have from nitro, or my anterior wall or my lateral wall in my patient might have from nitro. So something that all of these studies pointed out is nitro has a serum half-life of approximately 3 minutes. So you'll see some variation there of like 1 to 4 minutes, which is why we say we give it every 5. So it has a serum half-life of approximately 3 minutes. So if a patient does have an adverse effect, if they do become hypotensive or they do become a little bit bradycardic, it's likely to be pretty transient. It's likely to last just a few minutes before that half-life of nitro is gone. So what that 2017 study classified as an adverse effect was a heart rate less than 60, a systolic blood pressure of less than 100, or a drop of 1/3, so a systolic blood pressure drop of 1/3 of its initial value, a GCS decrease of more than 2 points, syncope, arrest, or death. So this study in 1989 of 40 patients just classified an adverse effect of a decrease of 30 or more millimeters of mercury in the systolic blood pressure. This 2017 study actually looped in a lot more signs and symptoms to be an adverse effect in their study, which is good because it kind of further enhanced the point that nitro can cause adverse effects, but it doesn't really cause any more adverse effects in that inferior RV wall in my patient than it does in any other cardiac region. So that doesn't mean to go ahead and start blasting everybody with nitroglycerin who's having a right-sided MI. You obviously still have to go off protocols. You have to go off your medical director's guidance. But really the whole point of me telling you this is I do think that we will see, I don't know if it'll be the next AHA update, but I do think this could change from the AHA recommendation. And I think this could change from a local protocol standpoint, that we may no longer be told to withhold nitrates from that inferior and right-sided MI patient, that as long as we have an IV in place and we have fluids ready, the benefit of nitro far outweighs the possible adverse effects that they could have. So another really interesting thing here was from these studies were that nitro administered to isolated inferior wall MIs, so just elevation in 2-3 and AVF, the right side was fine, had the lowest number of adverse effects. So I think that's important to call out because if you ask in your firehouse now, there's probably some people that are under the impression that if they have an inferior wall MI, I am just period not giving nitro because of the fear or the worry with that right-sided involvement. What these studies found was inferior wall MIs alone, isolated inferior wall MIs, so that occlusions down the posterior descending artery, those types of MIs actually do the best with nitro. So the patients who actually will benefit the greatest and have the lowest number of adverse effects from nitroglycerin, sometimes those patients don't get it at all because of a fear of right-sided involvement. So it's definitely something to keep in mind and think about as we start to see these patients in the field. So again, that QR code's there. You can scan it and it'll take you to this meta-analysis here. I can also send it out if you'd like me to. Just reach out afterwards and I'd be happy to provide it.